have a lot of interest in what's going on next door as well. It's an honor to be here. Thank you for coming. My name is Wendy Medeiros. I'm an occupational therapist and a certified hand therapist. I'm the owner, inventor, and manufacturer of the wrist widget. Since 2006, I've dedicated my career to the treatment and management of TFCC tears. And since then, I've collected data on over 45,000 cases. The wrist widget has touched over 1 million wrists worldwide. It's now copied and available everywhere. Take a close look at this. What do you see? On the left is a patient with a TFCC tear and positive ulnar variants. And on the right is the same patient at the same time with an X-ray with the wrist widget donned. The only purpose of the wrist widget is to keep the distal radius and ulna together. Hold them for a period of time with a non-elastic, no compression to the ulnar head. And I propose that the common knowledge now that positive ulnar variance causes TFCC tears, that there are actually TFCC tears cause ulnar variance. At the beginning, frankly, I didn't know what the wrist widget did. No clue, except people kept asking me for them. And I published my first case study on to answer the question: is it possible for the TFCC a tear to heal conservatively? And I'm here to tell you that most tears of the TFCC can heal with conservative management. Currently, the tools that we use to diagnose a TFCC tear are flawed. The access to medical care on this planet is poor. Most people don't have access to our care. They don't have access to doctors and MRIs and CT scans. The road to diagnosis is long. The road to treatment, the road to outcomes is long. When I started, the average person took a year to get care. The weight-bearing test was inspired by a test out of Japan, the PRESS test, which demonstrated 100% accuracy in defining TFCC tears. I don't know why this was forgotten, but I decided to take this test to an objective level using a non-digital scale. A non-digital scale is readily available, costs 10 Singapore dollars, 12 Singapore dollars, 12 euros, $10. It used to be easier to find. It's a little bit harder to find, but most places you can find a non-digital scale and you can assess your wrists yourself. A digital scale does not work. A non-digital scale measures dynamic weight similar to a grip strength dynamometer test. A digital scale measures static weight. Don't use a digital scale, use a non-digital scale. It is a tool to define a lot of things, and it should be part of everybody's clinic and practice. So what we have been doing since day one is collecting data on age, height, all kinds of date of injury, mechanism of injury. We've looked at x-rays, MRIs, CT scans, doctor's reports, your therapy reports. We've added stool tests and blood work. We're looking at a lot of things, and we've collected so much data, we're not sure really where to begin analyzing it. I spent 5 years going around the world looking at normal weight-bearing tolerance in the adult human wrist, which is surprising that that has not been done. I took a sample of weight-bearing tolerance in people from tall societies, small societies, young societies, old societies, a huge diversity of different populations to get normative weight-bearing data. What is the normal weight-bearing capacity of the adult human wrist? Published that in 2000. And what we learned is that there's no difference between right and left, dominant and non-dominant wrists. We know that weight-bearing is largely defined by age and height and gender. These are worth looking at. Now, these are a large population, and so in this society, it tends to be smaller, and so you have to adjust accordingly. And you can see at a woman at 55 to 64 with a lower height has almost half of the weight-bearing tolerance than somebody, a male 18-year-old. This is in pounds. I'm sorry, it should be in kilograms. What we also learned is that there's very important landmarks. The normal weight bearing in the adult human wrist is 70 pounds or about 30 kilograms. That's the average. We started to notice that when they had less than 20 kilograms of weight bearing tolerance, they had non-functional wrists. When they had more than 29 kilograms, they had loadable wrists. I define a stable wrist as one that's over 20 or 45 pounds, and an unstable wrist as below that. The red zone is 9 pounds. It's a red zone, and it needs to be monitored very closely. But most people with TFCC tears have functional weight-bearing tolerance. So now we know weight-bearing norms in the adult human wrist. We have a control, which is the uninjured wrist. We know that there's no difference between right and left, dominant, non-dominant. We know that the landmarks, there's functional landmarks, which are worth noting. We know that it's based on age, gender, and height, likely bone density. We know that when you start to strengthen a wrist that is unstable, it does more harm. That strengthening an unstable wrist does not improve stability or function. It does more harm. We know how to define the strengthening program or the rehabilitation program by their weight-bearing numbers. The TFCC specifically, let's just talk about the TFCC. It is the only injury where when you put weight through the wrist, first thing you do is you measure the uninjured wrist. Palm flat, arm not in front of you, not over here, not behind you, right here. No radial and ulnar deviation, no rotation, straight, elbow straight. You ask the patient to push down as hard as they can. As hard as they can. As hard as they can. That's your norm. You test the injured very carefully. You want them to go slowly. You test it without anything on the wrist, and you measure at what point that starts to hurt. Then you take non-elastic tape or the wrist widget, and you squeeze the two bones together. And the only injury that responds with a significant change in weight bearing is the TFCC. If you don't see those dynamics, the injury is not to the TFCC. You have to look elsewhere. MRIs are not a good tool to understand what's going on. Okay.
Or the wrist.
All right. So you do the weight bearing test, and somebody has pain. Ouch, it hurts. And you put a tape or the wrist widget on, and you measure, and it changes. You know right then and there that you have a mild, moderate, or severe tear. And but you have to see the change in weight bearing tolerance that's significant. I've established and worked really hard at developing a protocol to answer the question, how long does it take for this to heal? How long will it take for me to go back to work before I can play tennis or go back to work? And this test is the test that measures that. It tells you you need 65 pounds or 29 kilograms of stability to go back to work. Now, you're going to have to adjust that down for this population, for the age and height and the range. In general, the answer to that question is you need 65 pounds or 29 kilograms of stability in the wrist before you go start loading it. And most people, what they do when they have this injury is it feels pretty good. They can function with it. They can't load it, so they think it's fine. And they go out and load it again. And that is what keeps them from finding full success with just doing what they normally do. People that don't choose treatment describe this going on for years and years. So the wrist widget or tape needs to be worn like a stitch. Hold the radius and ulna together for a period of time, and then wait for it to heal, and then test it again. And when it's fine, you can go back to normal load. There's moderate tears are obviously a little bit longer. And interestingly, central tears and peripheral tears behave quite differently. Central tears are interesting because somebody who has a complete central tear, they go from non-functional to functional right in front of you. So they go from 9 pounds of kilograms of weight-bearing tolerance to completely normal right in front of you. Those take longer to heal. They have to be held for 3 months. Peripheral tears have a more gradual improvement of weight-bearing tolerance over the course of time. They plateau at 4 to 6 weeks, but then they go up progressively after that. If followed properly, it's 3 months is the long end of the curve. The longer you have it, the longer it takes to heal. The earlier you diagnose this, the faster it is. You can get an early diagnosis within a week of injury, and you're looking at half the time of healing. So instead of 3 months of healing, you're looking at 6 weeks, 4 weeks of healing time. So early diagnosis and early intervention really makes a big difference. Okay, of all the complaints that we get, we talk to thousands of people all day, every day, all day, over many years. The biggest one is that the rehab makes them worse. It's a difficult one to hear. And the reason that is, I think, is because we're just kind of strengthening when there's no stability. So if you have a weight-bearing test, just know that you can't strengthen unless you have a stable wrist. There's a lot you can do, just not standard wrist flexion extension exercises, supination exercises with a hammer. There is a rehab program which has taken a long time to articulate that I'll go over a little bit. I don't have that much time here. What we see is a pattern, and I know you guys are seeing this as well. Allison, I know, has seen this a lot, of weakness in the extensors, subscapularis, latissimus dorsi, teres minor, triceps, and caneus. Those need to be strengthened first before you start addressing the wrist. And the brachioradialis is important. This is the subscapularis, and this we look at everybody.
This exercise targets the subscapularis muscles. It is difficult for most people to do, but an important component to your TFCC strengthening program. Start with your hands resting palms up on the small of your back with your elbows pointing downward. Raise your elbows, wrists, and hands up, and do not let your wrists touch your back. Move your wrists up and down your spine slowly.
That's one.
This exercise targets your rotator cuff muscle.
We know this. This is important above the head. Triceps and anconeus are really important. In the second half of this, I'm going to talk about differential diagnosis, because the treatment for ulnar-sided wrist pain, we're not talking about TFCC tears. We're talking about ulnar-sided wrist pain. When the nerve is involved, dorsal ulnar, if the nervous system is involved, it is a whole nother pattern of dysfunction. You see no change with the wrist widget on, and I'm going to go over the details of that. What we're talking about here are people that have TFCC tears, ligament tears of the TFCC. So now we know what to tell people when they have a TFCC tear. When can I go back to work? And you can do the weight-bearing test. You can compare, watch them over the course of time. We know how to give them, what exercises to give them to keep them strong and be able to tolerate that load. And we are collecting data still to this day, and it's getting more sophisticated. And I would encourage you to reach out and contribute. We're going to be publishing normal weight-bearing tolerance in the young athlete. There are some interesting dynamics in children that are unexpected. We're going to be doing ulnar variance studies by X-ray, looking at bone density testing using the weight-bearing test to identify early cases of bone density loss. And there is an interesting subset of people that are worth noting. These are people that wake up with ulnar side of wrist pain and unstable wrists out of nowhere. And we're finding a direct correlation with the autoimmune system. Please keep in touch. I try to share as much information as I can with you, and I post stuff regularly with new insights. And I really like to hear from you. And I guess I'll just go right into my next differential diagnosis topic. Is there any questions from here? All right. I wasn't sure if I was going to be in a different room with the same people or not. I do need to note here that there is much higher incidence of ulnar-sided wrist pain than I ever imagined. 25% of laborers will develop ulnar-sided wrist pain, 10% of the general population, 100% of wrists that are studied under cadaver will have deterioration of the TFCC. There's not enough of us to treat all of them, and access to our care is really difficult. It does affect men and women equally, and interestingly, the group of people that we see the most are the 18 to 25-year-old. These are the tests that we use to rule out TFCC tears, and they're deplorable. They need to change. These are horrible. They're horrible. These aren't loading. I did go through a great length to help people who have ulnar-sided wrist pain figure out what's wrong with their wrists. MRIs are a horrible tool. X-rays are terrible. CT scans are horrible. We need a better way to diagnose TFCC tears. And the weight-bearing test is simple, easy, and accurate. The research that I presented here was a comparison of MRIs and on 100 cases and the weight-bearing test. First question you want to rule out is, do you have painful weight-bearing? Does it hurt to push on your wrist? If yes, the next thing, does it change with the wrist widget or with tape? If it does, you know it's a TFCC. If it doesn't, what is it? All right, the most thing we commonly see is Flexor, Carpi, Ulnaris, and pisiform pain. It's the most common injury that looks and feels like a TFCC tear. These people have, I'm going to go specifically through this, but this is the long list of other things that could be wrong that cause ulnar-sided wrist pain. Flexor carpi ulnaris is interesting. There's pain with weight bearing, but it doesn't go away when you stop weight bearing. It aches and continues afterwards. It can be pretty disabling. It causes pain with wrist extension and ulnar deviation. It appears like a spasm, like you wanting to, you just light up here. And they don't like the wrist widget. They don't like tape around the wrist. It's irritating. It doesn't help them. Feel supportive, but they don't really like it. There's no significant change in weight bearing at all. The wrist widget on. When we look at these, and we've looked at these very closely, what we see, that we took this from Chinese medicine, is that the Flexor Carpi Ulnaris is related to the heart. And oddly, when we start taking blood work, which we do on anybody willing to give it to us, is we do see that these people are terribly dehydrated. Their blood work is dehydrated. They are dehydrated. And when treated with an aggressive hydration, their symptoms resolve. That is worth noting. They also have spasms in the bottom of their feet and their calves and their hamstrings. Hamate fractures are not something we should be seeing online. We should not be diagnosing hamate fractures, yet we are. What these people present with is very painful weight-bearing tolerance. And there's no change in the weight-bearing with the wrist rigid on, but there's a significant loss in weight-bearing. Their weight-bearing is easier when it's in a gripped position. So you take a weight and you do a gripped weight-bearing test, their weight-bearing goes up. This one's really interesting because if you see people with really bad weight-bearing tolerance, like 10 pounds, and you put them in a gripped position, they have a positive pull test, they may have some ulnar nerve symptoms, you put them in a grip, their weight-bearing is a little bit higher, but that's a hamate fracture. And a carpal tunnel view x-ray or bone scan, usually carpal tunnel view x-ray will look. And we get a lot of these. We get way too many of these. And so you guys should be on the lookout. Scapholunate tears. Scapholunate and TFCC are brother and sister. They work together. One affects the other and equally back and forth. They both have pain with weight-bearing tolerance. So it's really difficult to distinguish it. If somebody has a scaphoid fracture, their TFCC is going to start hurting. If somebody has a TFCC tear, their scapholunate is going to start barking. So you have to distinguish the two. And the way to do that is an angled test. There's no change in weight-bearing with the wrist rigid on in a scapholunate injury, or scaphoid fracture, scapholunate ligament tear. There's no change in weight-bearing with the wrist rigid on. But if you take the angle off the test, instead of at 90 degrees, you go to 45 degrees. That normally drops a normal human wrist weight bearing, but in the scapholunate, it drops it quite a bit. Scapholunate always have clunk. TFCC never have clunks. You can get it with a weighted wrist flexion extension. TFCC tears never have pain with wrist flexion extension. If they do, the scapholunate is involved, or you've got to go another route. This systemic issue I alluded to earlier, and that is this group of people that wake up with non-functional wrists, both wrists, bilateral. They have bilateral loss of weight-bearing tolerance. That's significant. That's not, there's no particular cause. And what we find is their gut is involved in a big way. And so we started doing a gut analysis, a comprehensive gut analysis, and what we're finding is some really interesting things. Giardia, H. pylori, some parasites. We're seeing SIBO, and when treated, their ulnar side of wrist pain goes away and their stability returns. That's worth noting. Yet, a lot of people here don't have access to those tests. Those are very sophisticated tests that have been a response to the gut project that started 5 years ago. That was an assessment of gut bacteria over 1 million people. And those results have really made a difference in our understanding of the human gut. But most people don't have access to that. So in those group of people, if they can get a stool test or a urine test and a blood test to look at some signs that they might have some issues with their stomach, that's great. If not, we do recommend intermittent fasting, because you do find that the intermittent fasting starts to change their ulnar side of wrist pain, and that's an easy thing for everybody to do. We try to do a long stretch of no eating to see if that's a contributing factor. And the investigation is worth noting. It's worth noting and worth going down that route, because that's a much faster route than treating an unstable wrist. So, next part is people that have normal weight bearing. And we see this a lot. There are injuries to the ECU, and that are, we know about those, are tendon injuries. These people have normal weight-bearing tolerance, period. But if they have a TFCC tear, the longer they have it, the more severe it is, you're going to find the ECU starts to bark. So if you identify the TFCC and you know their ECU is subluxing, you know they're interconnected. If the stability of the wrist is returned, the ECU stops subluxing and calms down. So, yet there are cases of ECU-only injuries, and those cases have pain-free and normal weight bearing. The treatment is completely different. We all know what that is. The other thing that's interesting is the flexor pollicis longus. We see this in distal radius fractures. As you know, 50% of all distal radius fractures involve the TFCC. The weight-bearing test is flawed because they don't have full weight-bearing. But if you take the thumb off the scale and you do the test and their ulnar side of wrist pain resolves, you know that the flexor carpi, the flexor pollicis longus is involved. Other odd things are the extensor retinaculum. The nerve. The longer you have a TFCC tear, the longer you've lost your stability in the wrist, the higher the chances are that you're going to have a nerve involvement. And the nerve involvement makes it really hard. It makes it really hard. We do that once somebody has an ulnar nerve involvement, it takes a team of people to help them and needs to be identified, addressed, and treated in the clinic. Our hope is that we can identify these, treat them early, move them along the way so they don't develop ulnar nerve problems. These too are related to inflammation in the gut. We're seeing ulnar nerve problems start up when they've had the TFCC tear, and then the ulnar nerve starts to bark. And a really good history of their medical health, when it started, how it started, what their symptoms are, when their nerves started, will help you kind of guide them steer them towards getting some blood work. Ulnar nerve is usually, they need a lot of minerals and a lot of iron. And so I have a ferritin test run because I'm super curious about this, and ferritin is very low in most people that have ulnar nerve problems. So their usable iron is low. And you know, when you look at so many blood work, you start to see trends. We don't see trends like certain medications that people are taking. We don't see other trends. Low iron with ulnar nerve is a trend. Ehlers-Danlos affects stability of the wrist. We all know that. Pregnancy does some interesting things to weight-bearing stability. Menopause does some interesting things to weight-bearing stability. Puberty does some interesting things to weight-bearing stability. As children go through growth spurts, their weight-bearing is really dynamic. It goes up and down and up and down. I think I covered it. It's been a pleasure. Thank you for having me.